Yes, done. Thank you.
We welcome you, Ramesh sir, for today's RDLS session for Mizoram SACs. We can start the session, sir.
Good morning, all. Thank you for joining this session. I'm Dr. Ramesh, serving as a public health specialist at the Centers for Disease Control and Prevention, India office. So this session is going to be practicum of what all the medical officers or the ART center staff are supposed to be doing. This session will also review most of the OMs that we have received from NACO and how dolutegravir should be transitioned or switched or substituted to appropriate regimes. Very important because now we are in the era of optimizing the drug regimens for HIV positive patients. We have several regimes, but how dolutegravir is going to play a role is one important thing. And what are some of the operational and some real technical things that the staff should know? Please be free to put up your questions in the chat box. We'll be able to respond immediately as you put up your questions. And there will be a set of questions that keeps on popping up on the screen. So I want all of you to answer those questions. Until then, possibly I as a presenter will not know whether the audience are getting the information, requisite information or not. So to start with, let us see what is the mechanism of action of DTG. Before that, I want all of you to open your chat box and put the answers for this question. We have almost 24 participants. So I'll be looking for responses from at least 20 of them for each of the questions. So question A, DTG refers to darunavir or dolutegravir. In the chat box, you can put A1 or A2 as your answer. A.1 or A.2. Fast, we will not have so much time, but I encourage all of you to please use the chat box. Yes. There, I just got 3 responses. Faster. Some more. Only Jenny, Christina. I'm just seeing the same names. Some more. Only 10 of you have responded. Good. Yeah, okay. You're also answering for the second question. Okay, dolutegravir is a protease inhibitor. Okay, good. Third one also you can put up. Raltegravir and dolutegravir belong to the same class of drugs. For the answer C, I just got from one center. For the question C. Some more? Okay, good. So someone raised a hand. Okay, so most of you have answered them correct. DTG refers to dolutegravir. Dolutegravir is a protease inhibitor now, and raltegravir and dolutegravir belong to the same class of drugs. True. So once we have this basic understanding of the very important fundamental questions, let us see next part of the session. What is the difference between DTG and TLD? So please remember, DTG is one single drug, okay, which is used in combination with some other drugs. So it is an integrase inhibitor, all of you know that. And TLD is a fixed dose combination of tenofovir, lamivudine, and dolutegravir. So TLD means it has three different chemicals or three different drugs in one capsule or in one tablet. DTG is just one single drug, that is a D part of the TLD. So don't think DTG means it is three drugs, D for something, T for something, and G for something. No, it is dolutegravir, one drug having the name DTG. For example, TLD, when I say, yes, these are three different drugs, tenofovir, lamivudine, and dolutegravir. So that is a fine difference that I want every one of you to appreciate. Coming to the next, you have seen this slide. Most of your medical officers have seen in your trainings and all. So if you see here, we have integrase inhibitors, two integrase inhibitors in the center of the slide, that is raltegravir and dolutegravir. And you also can see under the protease inhibitors, darunavir. So protease inhibitor, darunavir is a protease inhibitor, dolutegravir is an integrase inhibitor. Now, why I'm emphasizing on these two differences is, as we go through the different regimes that a patient should be put on in a second line or a third line, currently we are using darunavir in second and third line treatments, in the management of second and third line. And we are also now going to introduce dolutegravir. So you should not be confused while writing in your white cards or any prescription. DTG stands for dolutegravir. DRV stands for darunavir. So suppose if a patient is on a second line regimen containing darunavir, don't just write D and stop your prescription, because the pharmacist or any other person will not understand what does the D stand for. Is it for DTG or DRV? So encourage everybody to write the full form. I mean, at least these three chemical short names as much as possible in the white cards. Now, once we understand the importance of the prescription practice that we need to have to differentiate between dolutegravir and darunavir, you've seen again this very important slide of the life cycle of HIV and where these integrase inhibitors act. So again, focusing on the center of this human cell, you see the stage of integration of HIV DNA into the host DNA. And that step is called as integration. That is, a host DNA is getting integrated into a viral DNA. So at that point of time, you have an enzyme called as integrase, which helps it. So our drugs, all these dolutegravir, raltegravir, will actually go and act at this site, preventing the host and the viral genome to actually integrate. So this is a step where integrase inhibitors act. Now we have understood three important things until now: that there is a slight difference between the nomenclature of the drugs between dolutegravir and darunavir, and it belongs to a class of drugs called as integrase inhibitors.
And to
And
speak the English a couple of minutes.
hello. Okay, so we know the difference of the drug. We know where it acts and which enzyme does it inhibit, and what is a group of drugs. With these critical pharmacological aspects that we have, let's go to the second part of the session. Why dolutegravir based regimes? We had until now NRTA and NRTA based regimes. We had PA based regimes. We had NTRI based regimes. Now, what is this dolutegravir and why is it so important in the current era? So here again, I would uh, want everybody's attention. So you see, the first and very important thing is any drug should act on the virus very rapidly, and that action should be there for a sustained period of time. It's not that one drug acts within 2 weeks and then the effect of the drug remains only for another 2 more weeks. So we do not want such type of drugs. We want a drug which will immediately act on the virus. When I say act on the virus, that means it suppresses the viral load and it maintains that suppression for a continued interval of time. So I want a drug that will rapidly act, and once it rapidly acts on the virus, it also has to sustain its effect for a longer duration of time. So these are the two important things that any one of us will consider if you want a drug. So similarly, this drug dolutegravir has a rapid a viral suppression, and it will sustain its efficacy over a period of time. For example, there was a study done. The study name was a single study where all patients who were not on ART, when I say ART naive, that means patients who are not on antiretroviral therapy, almost around 800 patients who were not on antiretroviral therapy, when they were getting initiated, they were put upon two groups of drugs. One is dolutegravir, abacavir, and lamivudine. 3TC is lamivudine. So that is one group of drug. And the other group of patients were given TDF is tenofovir, amitriptyline, or lamivudine, and efavirenz. So our current TLE, so they were trying to demonstrate the difference between TLE and ATD, that is abacavir, TLE, and DTG. Sorry, 3TC is lamivudine and DTG. Now, when they have studied in these patients, you see that patients who are on dolutegravir-based regimen had undetectable viral loads within 48 weeks. That is almost around 90% of them, and 80% in the other group had a undetectable viral load within 48 weeks. So that means within 4 months, or if you take the difference between these two, there is almost a 10% difference in attaining the undetectable viral load. Now you see the other group, that is, then we try to see how long do these patients remain undetectable. If you see, almost around 80% and 70% respectively had an undetectable viral load even after 48 weeks, or another additional 48 weeks, you see that they remained on virally suppressed. So this difference is just showing us if whenever a patient is put on dolutegravir based regimen, he will attain viral suppression early, and the effect will be sustained for a longer period of time compared to an NNRTA backbone based regimens. That's what this particular study has demonstrated. Now let us see the same thing in a graphical form. Now the yellow color line that you are seeing will stand for TLE based regimen, and the grayish color line stands for dolutegravir based regimen. You can appreciate from this graph that the gray color line is superior. That is, it is standing ahead of the yellow color line. That means what it says is, you just observe the oval shape, the purple color yellow shape, which is trying to indicate that TLD based regimens within, okay, within 2 or 3 weeks are, I mean, within around 6 weeks are able to have a proportion of patients with less than 50 viral load copies, compared to the yellow color one, which is having a relatively lower number of patients with viral suppression. And you see the sustained one, even after 96 weeks, at the 96th week, you still have higher number of patients with suppressed viral. So the takeaway is, number one, rapid viral suppression, and the second takeaway point is sustained viral suppression. Now, the other very important thing that we want our patients to have is, our community to have is, this drug should not have side effects. For example, most of you who are in the ART centers, when we were transitioning from nevirapine to efavirenz, you would have observed that most of the patients would be complaining of, oh God, this orange color tablet is driving me crazy. There are many nightmares coming in. I could not get good sleep. So these are some of the complaints that means we do not want the patient to suffer from all these. The drug should be tolerated well. So one of the parameters that we look for tolerability is, it has to have a lesser side effects. So in this study, when they have compared dolutegravir and an efavirenz based containing regimens, what we have observed is that most of the patients, that is almost 10% of the patients, compared 2% versus 10%. So there is more than 8% who have discontinued efavirenz based regimen, who are on efavirenz based have higher rates of discontinuing, because there is so much of side effects that we see for efavirenz compared to a dolutegravir based regime. And even at 96 weeks, that means there are two types of side effects. That means early within 48 weeks, you see some side effects, and there could also be prolongation of the same side effect, or number two, there could be some late occurring side effects due to dolutegravir. Sorry, very less. So this slide is trying to show you that either short-term or long-term side effects are relatively lower, number one. Number two, because of relatively lower side effects, the retention, that means you are not losing more number of patients on dolutegravir. So that means your LFU rates or retaining patients on the therapy is going to be enhanced. So that is the third very important point we need to understand, why we are going to use dolutegravir based regimes. Now, it has a higher barrier to resistance. That means, very simply to understand, if you have an NNRTI based regimen as a backbone, as one of the drugs for the effective, highly antiretroviral therapy, and vis-a-vis you have a dolutegravir based regimen, what happens is dolutegravir has a high genetic barrier. So when I say high genetic barrier, that means this particular drug will not mutate easily, or it is not going to get affected by the adherence level so easily, so that the viral can easily mutate and it can adapt to resistance. So this slide says that DTG has a higher barrier to resistance. Now see in this particular slide, okay, on my y-axis is barrier to resistance, and on my x-axis is the potency of the drug. So there are two important parameters that we are comparing. There is a barrier to resistance and potency. Potency means the drug should have higher potency. That means it should act very effectively. So for example, if you take the current regimen, efavirenz based regimens, where do you find them? For example, raltegravir and dolutegravir. You can see from this evidence that raltegravir is in the bottom. If anybody is able to see, raltegravir is in the bottom. That means it has higher potency, but it is not at the top level. That means it doesn't have a higher barrier to resistance. Compared to see dolutegravir, which is marked, highlighted in red, that means this particular drug has a higher potency and a very high barrier to resistance. This is one important point that why we are using dolutegravir is it has a high genetic barrier and also higher potency to act on the drug. So these two are very important for us to understand. I'll give you just 1 minute. Try to see what is happening to the genetic barrier and the potency of the drug that we are going to use in the program. So if there are any doubts, just please put them up on your chat box. Any doubts? Okay, so if there are no doubts, now let's continue. The other very important one side effect that was observed in some of the longitudinal studies is, you know about the neural tube defect. That is a defect that occurs when from conception itself, where there is no closure of the neural tubes. So there was an early analysis of this data done, and there was also an update of it. So what we have observed is that there is a some risk associated with the neural tube defects. So this is one thing that we need to observe. And in the recent AIDS conference, there were many observations told that the risk is becoming lower and lower. So this you can compare it with efavirenz. For all medical officers who were earlier there when we first introduced efavirenz into the national program, we told that we should not give them in the first trimester or after conception till first trimester of pregnancy, because initially we did not have an evidence. We just had an evidence that yes, neural tube defects are common with efavirenz. But later, after 1.5 years, we have revised the guidance saying that now there are no effects you can give to anybody efavirenz, irrespective of trimester or conception status of the child of mother in childbearing age group. So possibly similar type of evidence is getting generated, but currently the evidence says that there is a slight risk of neural tube defects, and hence we need to be more vigilant in mothers, in women with childbearing potential, and who just have any conception in the recent past. So, and in the first trimester, we need to actually not put the patient on this. So we'll go in detail about this particular one side effect, but overall, the side effects are very minimal in dolutegravir based regimes. Now, we know that the woman with childbearing potential may not be able to take a decision, but we need to tell them certain other very possible prominent effects of dolutegravir compared to any other regimen. Suppose you need to explain it, a woman with a childbearing potential or who wants to get pregnant, we need to take some time and counsel them on these very important points of dolutegravir. So the benefits of dolutegravir are mainly the mother, if they take, there is a maternal viral suppression which can occur, and transmission to the baby is very minimal. And also the quality of life of the mother is improving. That is number one. Number two is sexually transmitted infections also, there is chances that they can prevent it. Then the resulting mortality or morbidity from dolutegravir is very less. So always the benefits should be weighed, or the risks. So what is that, what we are looking at? Is it the risk or is it the benefit to that? So blanket exclusion of the mother who all are pregnant is not a good practice, and it is contraindicated. You cannot just say that the mother is pregnant and I am not giving dolutegravir. That is not the notion that we all should have. We should have a notion that any woman in the childbearing potential, we need to counsel her counsel her and offer her the strengths and weaknesses of this particular regimen during pregnancy, and if they are going to become pregnant, when they should and when they should not. So these are some of the things we need to get acclimatized to and start trying to tell our patients. And not just the patients, but the counselors, all the ART staff who are visiting this, listening this, need to tell to your colleagues about this particular dolutegravir based regimes and this side effect. Okay, now we have seen all these. If someone asks you what are the benefits of dolutegravir, tuck, 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 what all we have seen until now: rapid viral suppression, sustained viral suppression, fewer toxicities, more potent regimen. There is a high genetic barrier, minimal drug interactions. This is also effective against HIV too. Okay, so it is unlike if a patient is on an RTA based regimen, and if it is HIV2, we were putting them on PA based regimens. All that is not required. Irrespective of which type of HIV the patient has, you can actually start dolutegravir based regime. So this again is another important point of harmonizing the drug regime across any population group. With this, let us again open our chat boxes. Okay, 4 point. DTG has high genetic barrier and high potency compared to efavirenz. You put the answer as 4.1 or 4.2. Faster? Just one response I have received. Only 3. What others are doing? Faster. Someone keep a tag on which center is not responding at all. Okay, what about the question 5? DTG is contraindicated in pregnancy. True or false? Is it 5.1 or 5.2? What about 6th one? DTG is safe after first trimester. Another 30 seconds. Good. Perfectly correct. DTG has high genetic barrier. True. DTG is contraindicated in pregnancy. No, you cannot say that. So 5.2 is correct. We cannot say it is contraindicated. We need to qualify in terms of women with childbearing potential, or during first trimester, or from conception to first trimester. So these are the qualifiers for that drug when it should not be taken, but we cannot make a blanket statement as such that it is contraindicated in pregnancy. And the next thing is DTG is safer after first trimester. Yes, DTG is safe after first trimester. Good. Thank you for, all for answering this. Now let us see the third part of it. Now, are there any adverse events or are there any drug interactions with dolutegravir based regime? Okay, so the side effects of dolutegravir are like you have insomnia, you have headache, dizziness, tiredness, and allergic reactions, and DTG associated weight gain. This is important. Not that every patient who takes DTG will gain weight. This actually is a very good sign if you look at a patients. If they're gaining weight, specifically our positive community members, most of them will have slimming and all other manifestations because of the earlier adverse events, like whenever we had stavudine, we had zidovudine, or the long-term toxicities we have seen like peripheral neuritis, or you would have also seen like mobilization of the fat, lipoatrophy, dystrophy occurring in certain parts of the body. But this particular drug it was observed that there is a weight gain in patients who were put on dolutegravir. This is only an observation. So possibly we need to try out in India and see whether there's a real weight gain that is going to occur to a patient. So now a question to all of you. If I have to monitor whether there is a weight gain in these patients, what is the parameter I need to look on every visit the patient is visiting to the ART center? Very simple. But if you punch it down, I think you'll start doing it. So tell me one parameter that you will observe in patients who are on dolutegravir based regime to observe for weight gain. Come on, chat box. Only two of you. Only Dr. Diana and Dr. Christine from. Only two of you are answering. What about others? I'm waiting. Only three of you have answered. Okay, the best one to monitor is body mass index, BMI. If you take the height and the weight, it is a better one. But if you do not have, it's okay. You can also just look at the weight. But body mass index is the better indicator to understand the weight gain in a patient. Okay. Now, these are all some of the side effects that we have seen. Now, important drug-drug interactions. For example, carbamazepine, use DTG twice daily or substitute with an alternative anticonvulsant agent. This is one important thing. So with patients coming with CNS manifestations of any seizures or any epileptic history, we could consider looking at whether the patient is on carbamazepine. So if on carbamazepine, possibly you do not, we cannot use a phenytoin or any other one. So we should look at what is the best one or increase the dose of dolutegravir. And who are on antihypertensive or hypos, you look at amlodipine, and then you see, if you're on any anti-malarial drug, okay? So then you see for an alternative anti-malarial, because amlodipine has, again, decreases the dose of dolutegravir. So metformin, again, who is on diabetic, this is again very important in our HIV practice. We do not look for, but patients who are on metformin, and dose limitation should not be more than 100 milligrams when used with dolutegravir. And we have to regularly monitor the glycemic index, glycemic control. Then giving prescription of all antihistamines or giving multivitamins or minerals, we just have to give a caution to the patient that use them 2 hours before or 6 hours after dolutegravir. And rifampicin, whenever we are using, we need to give a additional dose of 50 milligrams DTG, additional dose of 50 milligrams, or we need to substitute with rifabutin. So these are some of the very important drug-drug interactions that we need to bear in mind. Okay. Now is the real practical thing, what we are doing and what we are supposed to do, and what are the recent OMs that have been released from NACO, and how much of it we are following at the ground level. So if you see, this was the first OM. This is to say that all patients who are on alternate second line and third line PLHIV should be put on dolutegravir based regime. That is, if patients were on dolutegravir earlier, they need to now be substituted to dolutegravir based regimes. And even now, prospectively, if any patient is identified as second line failure or third line failure, the preferred drug that we are planning, that we are supposed to give as part of the program, is dolutegravir based regimes. And this already most of you are following it. So this was the first guidance telling that all patients who are on raltegravir with lopinavir or ritonavir or raltegravir with darunavir or ritonavir based regimens should be transitioned to dolutegravir based regimes. So now, can anybody tell me, looking at this slide, what is the difference that you see in transitioning a patient or substituting a patient or switching a patient from a raltegravir based regimen to a dolutegravir based regimen with and without viral suppression? So what is the difference in dolutegravir, in prescribing dolutegravir to an unsuppressed patient on raltegravir with either lopinavir or dolutegravir or with darunavir? What is that change in the prescription that we need to look into? Only Dr. Richard has answered. Come on, I'm waiting for others. What is the difference? You can see the slide, there is something staring at you. Whenever there is an unsuppressed patient, if you want to substitute, if you want to switch to dolutegravir based regimen, what is that we need to keep in mind? Yes, so the important thing is that we need to put those patients who are unsuppressed on a BD dose and not on an OD dose. OD dose is only whenever there is a viral suppression with raltegravir. Then we take this particular 50 milligrams should only be given single dose whenever there is a suppression. Whenever there is no viral suppression, then we are giving a double dose of dolutegravir, or a DTG 50 milligrams we are giving BD dose. Now again here also, if there is a viral load is done, and if a patient is on lopinavir, ritonavir, we also have to give him DTG based for all NRTA exposed patients with virological failure who need second line initiation, and second line failure patients who need third line. This is the drugs. So there is not much. So for everything, what you need to just remember is, if you're going for a second line initiation, dolutegravir is always BD dose, either for, except in cases where raltegravir, a patient is already on a raltegravir based regimen and he is failing, there you have to give a BD. But on a raltegravir based regimen and the patient is having viral suppression, then there is no need to give a BD dose, but an OD dose will suffice. And here again you see, whenever you are giving a virological failure, multiple NRTA exposed patient with virological failure who requires now second line initiation, there again it is only an OD dose. Again for a third line also it is OD. So this is one specific thing that I want you all to appreciate and remember, where you are going to give a BD dose. So come on, hands on your chat box now. All patients on raltegravir with unsuppressed viral load should be prescribed BD dose of DTG. True or false? Good. Now, we got another OM from NACO, switching from ZLN to TLD. So all patients who are on ZLN need to be put on TLD based regimen. So this was the OM that we received. And recently again we had another OM on 12th October on TLE transition, that is all patients who are currently on TLE regimen needs to be again transitioned to TLD based regimens. Now, there is a very simple process chalked out by NACO on how to do both these things. Now, whether a patient is on ZLN or TLE, how do we transition and what we need to look for? The critical thing here is check for the viral load. Whenever you want to transition, switch, other word, shift, whatever is the word you are looking at, the first very important thing what you need to have in your hand is the viral load of the patient. So if the viral load of the patient is less than 1,000 copies, switch to TLD. If a patient is on ZLN, switch to TLD. If a patient is on TLE, switch to TLD. Simple. If the patient's viral load is greater than 1,000, what you always do is we send the patient for a step-up counseling, identify the barriers of adherence, try to provide solutions to the patient, offer solution to the patient, and then repeat the viral load. If your repeat viral load count is less than 1,000, irrespective whether the patient is on ZLN or TLE, you are going to switch that patient to a TLD based regimen. But if a patient is having greater than 1,000 viral load copies, we need to, on a repeat viral load specimen, then we need to refer this patient to SASN and switch this patient to TLD. This is a simple process that we are doing. Now, the only difference between the TLD that we are giving in first line, the TLD we are giving in second line, what is the difference? Can anybody say, is there a difference in the dose of dolutegravir? Should dolutegravir be given BD to these patients who are failing either ZLN or TLE? Should they be given BD dose of dolutegravir? True or false? Dolutegravir should be given as BD to patients who have failed perfect. Very good. So it should not be given BD, but it is an OD dose. Good. Very good. Very good. So this is what you do for ZLN. But there is a slight change for TLD that you would have observed in the OM that you would have received in the last week. So what does this say is, if a patient is on TLE based regimen, and if you have a viral load copies, and this is only for patients who are greater than 10 years of age, okay, and weight is greater than 30 kgs. For them, this guidance is adults and adolescents. So you see, if there is a suppressed viral load, then you are giving TLD 1 tablet. But if you have an unsuppressed viral load, in unsuppressed viral load, if a patient is on ZLN based regimen, we are just transitioning that patient to TLD. But if a patient is on TLE and unsuppressed viral load, what we are giving, what is our important step for a clinical decision making is the hemoglobin count. If the hemoglobin is greater than 9 grams, then the patient should be put on zidovudine, lamivudine, and dolutegravir. So here zidovudine is coming for patients who have greater than 9 grams of hemoglobin. If you are having lesser hemoglobin, less than 9 grams, okay, with a past history or a current history, okay, or the patient is with multi-NRTI exposed, lopinavir, ritonavir, or dolutegravir, okay. So this is what you need to consider. Everyone is okay, and look at where tenofovir is being given in terms of hepatitis. Yes, we need to continue the patient on tenofovir based regimens. Is there any doubt in this OM that we received very recently? Okay, this question we already answered this. Now, yeah, okay. Now, how DTG is proposed to be used under the national program? We have seen all these and all guidances have come. There should be no ambiguity in how do we transition. But again, this will be most of the slides that I'm going to show you next are going to be the guidelines that we are going to be implemented. And you know that all new patients should be put on tenofovir, lamivudine, and dolutegravir based regimen, including all HIV 1 and 2 or HIV 2-1. Okay. Now, other alternative regimens where DTG can be used with, if you have a body weight less than 30 kgs among adults, then you can use abacavir, lamivudine, and then DTG once daily. All patients with high serum creatinine, again, abacavir, lamivudine. So this is going to be the alternative regimen for all adult patients. Special situations, I want you all to remember again, whenever a patient is on rifampicin containing regimen, there the patient should get an additional morning dose of DTG 50 milligrams. Now a question to all, should I discontinue this additional dose of dolutegravir after completing TB treatment? True or false? The statement is dolutegravir additional dose of 50 milligrams that we take in the morning should be discontinued after TB treatment. True or false? Yes, we are only going to discontinue that additional DTG that we are giving in the morning, but not totally removing of DTG. It is only that additional morning dose that we are asking that is to be discontinued after completion of TB treatment. Good. So I'm not going into which regimen to use, what regimen to use. These are all available and you can just look into them. Third line also, we are giving dolutegravir twice a day. Okay, right. Okay, now let us see in children what are the things that we need to remember. Very important again. So if any patient is having any opportunistic infection or anything, we need to stabilize the child on those. And then our prescription is heavily going to be dependent on the age of the child. If the age of the child is less than 6 years or less than 20 kgs, we are not going to give that child any dolutegravir based regimen. That is number one point you need to take away from this slide. Is dolutegravir should not be prescribed in patients, in children who are less than 6 years of age and less than 20 kgs. Now suppose the age is between 6 to 10 kgs and the weight is between 20 to 30 kgs. There we should not be giving tenofovir in these patients with dolutegravir, but we need to give abacavir 3-TC and dolutegravir. This is for patients between 6 to 10 years and the weight is between 20 to 30. And if your weight is greater than 30, age is greater than 10 years, definitely with no renal parameters, we need to give with no renal abnormalities in the renal parameters, then we need to give that patient the adult dose of TLD 3-TC plus dolutegravir. But if there is a known renal disease, then better to put the patient on abacavir 3-TC and dolutegravir. So you have to just remember three important points in children living with HIV. If any child is less than 6 years of age, we do not prescribe dolutegravir. If a patient is between 6 to 10 years and the weight is less than 30 kgs, Here we are giving dolutegravir along with abacavir. Only in cases if the age is greater than 30, weight is greater than 30, and age is greater than 10 years, there we are giving a tenofovir is being introduced in that child. But if there is a renal parameter, known renal abnormality, we are going to again put the patient on abacavir, lamivudine, and dolutegravir based regimens. Right, this is all what we have discussed now. And there is also a PEP going to come up in the newer guidelines. So recommended for PEP is 1 tablet immediately. And what is the tablet? What we are going to see is TLD again as part of the revised PEP protocols. And PEP drugs for children, ZLN is recommended as part of preferred, and third option as lopinavir ritonavir. Okay. So it is very important to see the availability of stocks. You see who should get an OD dose, who should get a BD dose, and note for the counselor specifically, whatever the ART center medical officer or the understanding needs to be disseminated to all your staff. And don't take it a panic situation whenever you have a pregnant woman or when you have a childbearing woman with childbearing potential. Certainly the information should be transferred and the decision of taking should be given to the patient, and we as providers should be able to give requisite information to them. So then key issues in women childbearing and all these needs to be taken care. And from now on, we need to use the version of the April version, and most of you are using. In that, we have again TLD and dolutegravir 50 milligrams separately being reported. And we have DTG job aids developed by NACO. These could be taken and circulated. Okay, so these are all the FAQs. And now coming to some of the very important points. If you have any operational steps that needs to be defined, or are there any operational challenges, so you could discuss, I mean, the SACS point person, whoever is part of this, if you want to tell all the ART centers on the operational steps that you have for your state in terms of how many states have, how many ART centers have received the dolutegravir based regimen. All this, if there are any suggestions, I welcome SACS to please disseminate the information. And very importantly, before I forget, uh, all the ART centers should target that every child who is in the program should be given the advantage of dolutegravir within the next 30 days. You can prioritize them for viral load, check their viral load, and please transition them to dolutegravir as indicated in the slide, less than 6 to 10 years and more than 10 years, weight bands of 20 to 30 and greater than 30. Please see that. And one important outcome of this particular call that I would want you all as medical officers to promise your SACs is that we want to ensure that every child who is in our national program in Mizoram will definitely get dolutegravir based regimen. And in the next MPR, we want to see that yes, every child whoever is there and indicated is getting dolutegravir based regimen. Yeah. Over to SACS if there are any intimations that you want to give the ART centers, or any questions from the participants is also welcome at this point of time.
Participants can unmute themselves now if they have any questions.
Okay, thank you all. There are no questions or any announcements to all the ART centers. Thank you all for your participation and attention.
Yeah, thank you, sir, for this informative session. Thank you to all the participants for patient listening. We can end the session now. Thank you, sir.